This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Eris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today, we're looking at a fascinating new study from the journal Acta Neurochirurgica titled Mortality and its Predictors Among Neurosurgical Patients Admitted to the Surgical ICU in a Resource-Limited Setting, Experience from Ethiopia.
This is a timely paper, Ilara. We often discuss the latest intraoperative imaging or robotic platforms in high-resource centers, but a significant portion of the global neurosurgical burden is managed in resource-limited environments. This study gives us a window into Tikor Ambessa Specialized Hospital, or TASH, in Addis Ababa.
Exactly. TASH is Ethiopia's largest national tertiary referral and teaching hospital. It serves a catchment population of about 120 million people. The researchers conducted a retrospective cohort study between January 1, 2024 and January 1, 2025, reviewing all neurosurgical patients admitted to their surgical intensive care unit.
And for our listeners who haven't worked in these settings, it's important to understand the infrastructure. The study notes that their SICU has 12 beds and 8 mechanical ventilators. When you consider the volume of complex cases, trauma, tumors, strokes, that is a very tight bottleneck.
It is. They looked at 140 patients in total. The primary outcome they were measuring was mortality, specifically whether the patient died during their ICU stay or was discharged or transferred with clinical improvement.
So let's get straight to the headline number. What was the overall mortality rate in this cohort?
The overall ICU mortality rate was 23%, which accounted for 32 patients.
That's a significant number, nearly 1 in 4. But the real value of this paper lies in the multivariate logistic regression analysis. They identified 4 independent predictors that were statistically significant. Shall we dive into those?
Let's start with the strongest predictor of mortality, ICU-related complications. The adjusted odds ratio, or AOR, was a staggering 7.8.
That is a high AOR. In the context of neurosurgery, we aren't just managing the primary insult, like a traumatic brain injury or a tumor resection. We're managing the systemic cascade. The paper mentions that systemic effects associated with neurological illnesses predispose these patients to complications like altered drug metabolism. When those complications hit in the ICU, the risk of death increases nearly 8-fold.
And that ties back to the complexity of these patients. The study highlights that neurosurgical ICU care includes patients with CNS trauma, spontaneous intracranial hemorrhage, ischemic stroke, and SAH. These individuals require close monitoring because of the high risk of neurological deterioration.
Which leads us to the second major predictor, emergency surgery. Ilara, what did the data show there?
Emergency surgery had an AOR of 7.4. It was nearly as high as the complication rate. If a patient was admitted following an emergency procedure rather than an elective one, their mortality risk was substantially higher.
This makes sense clinically, but is sobering to see quantified. In an emergency setting, you're often dealing with a patient who hasn't been optimized. You might have a traumatic brain injury with an expanding hematoma or an acute hydrocephalus. The study notes that optimal postoperative care focuses on preserving cerebral perfusion by maintaining adequate CCP, cerebral perfusion pressure, and ensuring sufficient oxygen delivery. In an emergency, maintaining that stability from the ER to the OR to the ICU is a massive challenge.
Definitely. And the third predictor they identified was intraoperative blood loss of more than 1,000 ml. The AOR for this was 4.0.
A liter of blood loss in a neurosurgical case is significant in any setting, but in a resource-limited environment, the implications are magnified. We're talking about potential coagulopathy, the need for blood products that might be in short supply, and the resulting hemodynamic instability that can lead to secondary brain injury.
The paper emphasizes that continuous hemodynamic monitoring and targeted interventions are required to prevent those secondary injuries. If you've lost a liter of blood, your margin for error in maintaining that CCP is almost non-existent.
Which brings us to the fourth predictor, which I found perhaps the most poignant for this setting, the lack of continuous postoperative monitoring.
Yes, this had an AOR of 3.5. Even after adjusting for other factors, the absence of continuous monitoring was independently associated with increased mortality.
Let's pause on that. For our residents listening, think about why we have neuro observations every 15 minutes or 1 hour in the first post-op day. In this study, the lack of that continuous feedback loop was a killer. The authors mentioned that an ICU is a specialized facility that provides continuous monitoring and care, but it's also extremely resource-intensive in terms of both manpower and equipment. In a 12-bed unit serving a massive population, the intensity of that care can be stretched thin.
It highlights a critical point the authors made in the background. In developed countries like the US, ICUs account for 15 to 40% of total hospital expenditure. In a resource-limited setting, providing that level of monitoring is a constant struggle. The study points out that the absence of comprehensive data on admission trends and outcomes limits the ability of healthcare providers to optimize care.
Right. They are essentially flying without a map until studies like this are published. The indications for ICU admission they listed, need for mechanical ventilation for airway protection, impaired consciousness, or the occurrence of postoperative medical complications like seizures or infections, are universal. But the ability to manage those indications depends on that continuous monitoring.
Exactly. To recap for our listeners, the 4 independent predictors of mortality were emergency surgery, AOR 7.4, ICU complications, AOR 7.8, intraoperative blood loss over 1,000 ml, AOR 4.0, and a lack of continuous postoperative monitoring, AOR 3.5.
It's a powerful quartet of factors. It tells us that mortality isn't just about what happened in the OR. It's about the status of the patient coming in, the emergency nature, and the quality of the safety net they fall into afterward.
It's a powerful quartet of factors. It tells us that mortality isn't just about what happened in the OR. It's about the status of the patient coming in, the emergency nature, and the quality of the safety net they fall into afterward.
The authors concluded that understanding these factors is crucial for resource allocation and improving patient management. They want to reduce morbidity and mortality rates by identifying who is at highest risk. And that's the takeaway for our practicing neurosurgeons. Even if you aren't in Ethiopia, these predictors, blood loss, the nature of the surgery, and the quality of post-op vigilance are the pillars of neurosurgical success. However, in a setting like TASH, these factors are the difference between life and death on a very different scale.
It's also worth noting the study design. This was a retrospective cohort over a 1-year period. It provides a real-world snapshot of the challenges faced by multidisciplinary teams, anesthesiologists, intensivists, and neurosurgeons working together in these environments.
Well, this was a sobering but necessary look at global neurosurgery. Any final thoughts on the paper, Ilar?
Just that it reinforces the need for specialized neurosurgical intensive care. The authors mention that treatment in specialized units have demonstrated clear benefits. Even in resource-limited settings, the goal should be moving towards that specialized continuous monitoring model whenever possible.
Agreed. Thank you, Dr. Ilara, for breaking that down. And thank you to our listeners for joining us on the Neurosurgery Hub podcast.
We'll see you in the next episode.
Stay sharp.